السلام عليكم ورحمة الله. يعني I'm assuming I'm live now. I'm just trying to أتأكد كده من مجموعة الأدمنز إنه أنا لايف على الجروب دلوقتي في طيب أنا أعتقد إنه باي تشيكينج على التليفون عندي أنا شايف إن أنا لايف. أتمنى تكون الصورة واضحة، وإحنا قعدنا we tried a lot to make الستريمينج as best as possible يعني. دلوقتي انا يعني it's a new way of streaming، فانا هشوف بعض الكومنتات من الادمنز ونشوف كده. يعني انا شايف جميل جدا، انا شايف الكلام الكومنتات ان الصوره كويسه طيب ممتاز. هنبدا اللايف ستريمينج ان شاء الله. and since I'm not sure يعني how many على الجروب could be just English speaking. أنا عارف إن دي الفيرست Egyptian group, but still it seems like some people are not بس من Egypt. فيعني يعني هكون على قد ما أقدر تكون الصورة إن شاء الله، تكون الكلام يعني بالإنجلش mainly. بس أشوف اللايف معايا هنا عشان أقدر أتحكم. طيب ممتاز. حلو قوي. أنا يعني so I'm gonna try to speak actually in English just in case there are some people who are just يعني English speakers. وبعدين anyway يعني أعتقد إن الإنجليش هيكون يعني perfect معاكم كلكم إن شاء الله. let's start the presentation. أتمنى الأول إن كل واحد يكون يعني بصحة وبخير، و stay home order is something new to all of us. So it's a new thing in life that I didn't even think it's gonna happen throughout my life. So everybody, I think it's a new experience for everybody. You probably remember we should have had a Middle East Academy meeting by the end of March. Yeah, last March, but it was postponed until October. Inshallah, we'll see you there. Anyway, now let's start the presentation. Now I'm going to talk about the reliable anatomical landmarks in scopic sinus surgery. And we are not going to talk about the very basics of the basics, which means we're not going to talk about the answering process, for example. We're not going to talk about the small details. We really going to go through the anatomical landmarks that you need as a surgeon in the complex cases or difficult situations or revision cases. Or just de novo cases anyway, but you need some landmarks to define for you a roadmap to go through the endoscopic sinus surgery, hopefully safely and effectively. By the way, this is a lecture that it's part of the lectures that we actually give in our biannual endoscopic sinus surgery course in Dubai. The last one was postponed because again of the corona issue. But I cannot post this picture without mentioning, of course, Professor Stemberger, that I had the honor to work with him for years in this endoscopic sinus surgery course in Dubai, and we always remember his achievements and his, all what his teachings in the field. Let me just check the message from, okay. So I think Muhammad Rantisi is saying everything's fine. So I cannot just go, post this picture without remembering him and, just have all the thoughts with his achievements in this field and the teachings that he added to this field and again, the honor that I had and the experience that I actually got by joining him in this course for years. Now, for endoscopic sinus surgery, while doing it, you are focusing in two things: is performing a safe endoscopic sinus surgery and an effective procedure as well. Now, why is that? Because if you do an endoscopic sinus surgery safely, it can be safe but not as effective. For example, by leaving behind a lot of the polyps, a lot of the disease, and by doing so, by the way, it's not actually safe because you're exposing the patient to more hazards in the revision cases, in the revision scenario, exposing the patient sometimes to adhesions or with safe is not actually may not be actually safe. And an effective endoscopic sinus surgery means you perform it so you can be effective. You can be effective by removing all the disease, but at the same time, you go through the lamina or the skull base, so you are not literally safe, although you have removed the disease and all that stuff. So you have to focus on both things to perform it safe and effectively. And at the end of the procedure, then you will feel happy, excited about what you have achieved in the procedure, and you'll see your team as well. In order to do so, you need to understand the anatomy very well. Now, what I mean by the anatomy is the anatomy not from like the anatomy that we have learned in the medical school, but really the anatomy from the endoscopic perspective, from the surgical perspective that you are operating on. And that's why, by the way, I started my endoscopic career by having this scholarship with Dr. Cassiano, and this has changed my career. Back in 2005 when I started this, my focus was to do an endoscopic sinonasal dissection a lot. We ended by 50 plus endoscopic sinonasal dissections, which enabled us to understand the anatomy very well, all the details, describe the relationships, landmarks, and all that stuff. And and we have worked as a team. So in the endoscopic sinus, this dissection manual. So that was the first publication in 2011, along with Amy, Anderson, Adam, Lori, and Bellaccio, and our mentor Cassiano, and then we republished this with so many additions in the 2017 edition that you also have on Amazon right now, I guess, or on the theme website. A lot of you already have it as well, and you will find in this a lot of the details that we are going to be speaking today, and also throughout the skull base sections as well. So that's the way for you to understand the anatomy very well, is to do a lot of dissections in this regard. Now, we will see as well that the endoscopic goes side by side with the radiologic anatomy. So you study all the radiology, and basically this is what we are doing in endoscopic sinus surgery. We are reviewing the radiology very well, and then we are applying this to what we see endoscopically, so it goes together. And when you have a map in your mind of the radiology that you see with certain landmarks that we're going to describe right now, you can perform actually the endoscopy as if you have a navigation machine beside you. Now, it doesn't mean that the navigation is not necessary. It just means that for most of the basic and the extended procedures, you can have a map inside your mind, tells you what exactly to do in the surgery. This is a picture that I always present in the beginning of the lectures, just to remind people about this misunderstanding. You see this? What do you think? Just give yourself a second to think what is wrong in this picture. I'm sure if some of you have attended some of our lectures before, you will know that what's wrong here is the superior turbinate. So the superior turbinate is not really, the turbinates are not really like ladders, just simple inferior, middle, and superior like this. But actually, the superior and the middle turbinate have this arrangement. They are not separate. They are not separate in the upper part. As you see, the superior turbinate and the middle turbinate are actually one thing in the upper part of the field attached to the skull base, and this part is called the conchal plate. You see this? This part is called the conchal plate, right? So you see the conchal plate is one thing, and it's the upper part of the superior and the middle turbinates. And as we go inferiorly, the superior and the middle turbinate, are actually separating from each other. Let me check if I can hide this. Hopefully I can. Okay, so just, okay. So yeah, as you see, they are actually separated as we go inferiorly to form the superior and the middle turbinate, and sometimes as well the supreme turbinate. Now we have, on the other hand, we have the inferior turbinate as a separate bone attached to the lateral nasal wall. As you see this also from the endoscopic view. So we are now looking at the right side, and this is the inferior turbinate on the right side. That's the middle turbinate, and that's the superior turbinate. And as you see, they are separating into superior and middle turbinate as you go inferiorly, but the upper part is one thing, which is called the conchal plate. And this is obviously the sphenoid ostium. So the superior, middle, and the inferior. And this conchal plate is important because it has much of the olfactory fibers that you have. And so injuring the olfactory plate will end the patient with hyposmia or even anosmia. So you don't want to go this. You don't want to go there and injure the conchal plate. And also the conchal plate is attached to the skull base. So if you injure it, you are also endangering the skull base and the CSF rhinorrhea for the patient. The second thing is also understanding the middle turbinate, three parts. I'm sure every one of you is aware of this. So you have the sagittal part, which is attached to the skull base, and then you have the coronal portion, which is attached to the lateral nasal wall and the lamina, and then we have the posterior portion. By the way, Muhammad Rantisi, if you hear me right now, I think I just receiving a message from a couple of people who just asked it to join the group again, maybe in the last 15 minutes or something. So if you can, please approve them. Hopefully they can join the show as well. That would be great. Thank you. So now, as you see, we have also the horizontal portion that's attached to the lateral nasal wall. Now, inferior turbinate is another separate bone from this arrangement. What's the closer? Why I like using the closer is something that you will find by the time it gives you an excellent way to review the anatomy, both preoperatively and intraoperatively. And the closer, so the closer acronym stands for different things, depending, just depends on the one who's describing the closer. I'm going to describe the closer right now the way I like to teach my residents and the way I like to use in the OR. So you'll find every letter of this referring to certain area in the field that would be great to review preoperatively in the CT and intraoperatively as well. Now the closer, the C stands for the cribriform plate and the fovea ethmoidalis, the L for the lamina papyracea, the O is the osteomator complex, Onodi cell and our cell as well, the S is the sinuses, maxillary, sphenoid, frontal, E for the ethmoid arteries, and the R to review the septum, turbinates, and the nasopharynx. First, starting with the C, remember the Kiros classification, which means you have a lateral lamella, or the distance between the cribriform plate and the fovea ethmoidalis, which is called the lateral lamella. The lateral lamella length can range from 1 to 3 millimeter, Kiros 1, 4 to 7, Kiros 2, 8 to 16, Kiros 3. Now, that's not the whole thing. Also, remember the posterior ethmoid roof. The posterior ethmoid roof also goes inferiorly as we go posteriorly. So that's an arrangement that's important to remember. Now, the question is, the posterior ethmoid roof, as it goes inferiorly, as we go backwards, how much inferiorly it's going to go? Because this is the second most common area for injury during endoscopic sinus surgery, and you need to understand where it lies in the field exactly, how much inferior. Now, you see that's posterior ethmoid roof. We have a very fixed landmark, very helpful landmark, which is called the medial orbital floor, or the MOF. And the question becomes, how far the medial or the ethmoid roof, the posterior ethmoid roof, is going to be from the medial orbital floor? And well, the first question would be, how much of the cases, or what's the percentage of the cases where the posterior ethmoid roof is actually going to be at the medial orbital floor? And the answer for this is 0. In normal, in normal conditions, I'm not speaking about that people who have meningoencephalocele or skull base abnormality or something like this. I'm speaking about normal population. There is no way that the posterior ethmoid roof is going to be at the same level of the medial orbital floor. It's going to be above the medial orbital floor in all cases, even in different races. However, there is a distance that's going to be variable between the cases, and this distance, well, I'm going to talk about right now. So here's the thing: when you are doing unsunectomy, middle metal antrostomy, you end up by creating a middle metal antrostomy, and once you do this, you see the medial orbital floor. What's the medial orbital floor at the end? It's going to be the floor of the orbit or the roof of your middle metal antrostomy. Now, this is a picture from our book, and now we are looking at the left side. And as you see, that's the level of the medial orbital floor. As we know right now, the medial orbital floor lies always below the skull base of the posterior ethmoid. So if we have this as a landmark, we can just enter the posterior ethmoids through the basal lamella of the middle turbinate at this level. Now remember, when you are in revision cases, when you have extensive polyps, when you have a tumor, when you have something that disturbs the anatomy for you, it's great to have your landmark in the field, then MOF, or the medial orbital floor. Let me show you this example in the video. So now we are looking at the left side, and this is the maxillary antrostomy, and now I'm putting my suction on the basal lamella of the middle turbinate at the level of the medial orbital floor. And you see the navigation is showing me that I'm going to be entering the basal lamella of the middle turbinate. Since I'm using this level as a landmark, I'm going to be entering through the basal lamella into the posterior ethmoid. And why is that important? Because remember, there is another way to say it. There is another way is to say enter the basal lamella in through medial, right? So you can just say in through medial. The problem that lies with our residents when you are practicing the endoscopic sinus surgery in the middle of extensive disease is you are not sure, you are actually not sure where in through medial is. You get disturbed, you get this, the field gets distracted, you get distorted, you don't confused what's in through medial in the field. But using the medial orbital floor is going to help you determine exactly where you are. So that's now I'm entering into the posterior ethmoid. Let me check. So I'm now entering into the posterior ethmoid and actually opening through the posterior ethmoid while starting at the medial orbital floor. But here's one thing I want to actually also mention. Remember, if you go, that's one important thing here. Now, if you go with your suction tip, instead of pointing horizontally, posteriorly, you are actually pointing superiorly. So what you can end by getting into the skull base. Remember, so I'm talking about using the instrument in the right way, horizontally at the level of the medial orbital floor, rather than pushing it superiorly into the skull base. Now, as I told you and mentioned in the beginning, the question is how far the posterior ethmoid roof is going to be from the medial orbital floor. This is something that you need to review in the CT scan preoperatively. So there is studies looked into that, and they showed by the collection of studies, you will see that the average is around 14 millimeter. So you see this distance is around maybe 16 millimeter in this case, and you have a standard deviation of 3 millimeter. So remember, you can have some patient that has the medial orbital floor, the posterior ethmoid roof lying, for example, 9 millimeter from the MOF. And this is called low-lying skull base, like you have in this case. You can have it a little bit like this as well, lying a little bit more down, like 8 millimeter, 7 millimeter, which is an extreme in the 99th percentile or something. So you know that you have a patient with low-lying skull base that you need to pay attention to. Okay? So again, once you use this medial orbital floor as a landmark, you can reach all the way posteriorly to the sphenoid and then go from posterior to anterior along the skull base in a safer direction, since you are going to a higher skull base anterior. So that's about the skull base and the claviform plate. Now going to the lamina papyracea. Now for the lamina papyracea, remember that there could be dehiscence, right? But I'm pretty sure that every single one of you is reviewing whether there is dehiscence in the lamina papyracea or not preoperatively, right? So, well, that's important, but it's not the whole thing. Remember also there is position of the lamina papyracea that we have came across during our career of endoscopic sinus surgery. I think I started looking into this back in 2010 until we published our study in 2015 when we analyzed hundreds of CT scans and patients to determine exactly where the position of the lamina papyracea and the impact of this on the field. Let me show you this. Now, the position of the lamina papyracea, so that's the usual arrangement. What you see right now is you have the middle meter antrostomy right here, and then you have a lamina papyracea that's pretty much in the sagittal plane of the middle meter antrostomy that you are going to create. Okay, or you can look into the attachment of the uncinate or attachment of the lamina papyracea into the attachment of the inferior turbinate. So you see the lamina papyracea in the same sagittal plane of this. Now, that's in 2/3 of cases, not in all cases. Indeed, let me check one second, just let me check. Okay, so I think I'm still live. I am there. Yes. I think things are fine because I don't have feedback on my screen, so at least now I can see the live video on my phone as well. Now, as I was just saying, that's not the whole cases. Some cases would be type 1, as I mentioned, 2/3, but some cases would be type 2, where you have the lamina papyracea actually lying in a more medial plane relative to the sagittal plane of the middle meter antrostomy or the attachment of the inferior turbinate. And you can end by entering through the lamina papyracea while you are dissecting the ethmoid cells, right? And there is also type 3 lamina papyracea where it actually lies laterally, and you can miss some cells on the lamina while dissecting over here. You can miss some cells on the lamina if it's type 3. Let me give you this. And you think, I'm sorry I don't have a feedback, but please mention in the comments before I tell so I can review this after the broadcast. What do you think this patient is? Let me ask you. What do you think this patient is? What type? Is it type 1, as we just mentioned? Is it type 2 or 3? The lamina. So I'm going to review your comments later, but hopefully some of you are going to mention the correct answer. And the answer is, it's type 2, obviously. And the reason is we have a hypoplastic maxillary sinus, and then you see the lamina papyracea lies more or less in a medial, as you see. It's also clear on this side. See the lamina lies medial relative to the middle meter antrostomy or the attachment of the inferior turbinate. And then you have a very narrow anterior ethmoid air cells, and you can enter into the lamina papyracea very easily. So it's type 2. This is the same patient intraoperatively. So I was asking my resident, by the way, to do the surgery while avoiding the lamina papyracea, and I'm going to show you what happened with her. So she has done already the middle meter antrostomy right there. You see that this is the inferior turbinate right there, and you see the lamina is there. The lamina is just in front of you as a surgeon while you are dissecting the ethmoids. And you might think this can be a cell or something, but by pressing on the orbit, by pressing on the globe, you can actually see the inward movement, as I just showed you, and you see this is the lamina papyracea. And it's not a cell of the lamina papyracea that has a transmission of movement, it's actually the lamina papyracea. On the other hand, when you have a lamina papyracea that's pushed laterally, and in this example also with dehiscence, you have to remember that you can have cells on the lamina that you need to dissect in order to clear. So I'm not sure. Okay, in order to clear the cells. I'm actually having a lag between what I see on my phone and what I see on my screen. But we have tested this before, and I think at the end everything is going to be fine in relationship to the audio and the video on your side, if you have a good internet connection. So I hope everything is fine. Muhammad, can you send me a message confirming that everything is fine? So, okay. So as you see, you have now cells on the lamina papyracea that you see I've been dissecting away from the sagittal plane, away from the sagittal plane of, see, this is the sagittal, this is the millimeter antrostomy, and you see the cells are far lateral to this plane. And then now I'm getting into the frontal sinus, clearing the skull base as well, postoperatively, as you will see. See, this is the frontal skull base, sphenoid sinus, posterior ethmoid air cell right here that I'm going to talk about in 10 minutes. And then you have the millimeter antrostomy, the lamina is clear as well. Now, moving, so that was about the cribriform and the lamina papyracea. Now, moving to the ostomator complex, onodi, and our cell, or the new cell that we're going to talk about. I'm pretty sure that a lot of you already know about the retromaxillary cell as well. So that's now about the Haller cell. The Haller cell, I'm starting with the Haller cell since it lies in the ostomator complex region. Narrowing the ostomator complex, and you might also enter the Haller cell thinking this is the maxillary, and it's not the maxillary. And the onodi cell, which you would identify by seeing the horizontal septum in the sphenoid sinus, right? So anything about this horizontal septum is going to be the onodi cell. Well, what other cell I'm going to be talking about is, as I mentioned, I'm pretty sure that a lot of you know about the retromaxillary pneumatization by now, since we have published this in 2016. But I'm just going to elaborate a little bit on how it looks like in the CT scan and what to expect in revision cases as well. So we have published this by looking at, I think, up to 1,000 cases in or sites in this publication that we did in 2016, the White Journal, and we looked into this retromaxillary area, and then we described this pneumatization in relationship to the medial wall, the lateral wall of the nose, either having type 1, or which is up to 3 millimeter, or type 2, 3 to 6 millimeter, or more than 6 millimeter. And then we have compared this to the Haller cell, right? So, the Haller cell, basically, that I just showed you is an anterior ethmoidal cell in the, as I just showed you, remember? I just showed you the Haller cell in the anterior ethmoid region, right? In the anterior ethmoid region right here, you see the answering process, you see the ostomator complex right here. Now I'm going to be talking about the retromaxillary cell, and as you see, we pretty much don't have any retromaxillary pneumatization here, but we have a little bit of just 1 millimeter of pneumatization. You have 6 millimeter of pneumatization of the posterior ethmoids here, and then the extreme type where you have more lateral pneumatization of the posterior ethmoidal cells at the posterior superior corner of the maxillary sinus. So that's an important thing to recognize. So comparing this cell to the Haller, again, this is the ostomator complex region, while we have the posterior ethmoid air cell and the the retromaxillary cell lies right here at the posterior superior corner of the maxillary sinus. How this is important, you see that this is a revision case. And by the way, the revision case was done kind of very nicely, but the surgeon missed this cell, and as you miss this cell, you actually miss the cell above it because you think this is the lamina papyracea, and then you end up by missing more and more cells. Again, this is a cell, and then you have actually, when you miss the retromaxillary cell, you end up with more disease in this region, which obstructs the posterior ethmoid and then obstructs as well the sphenoid sinus, ostium, and the posterior group of the sinuses in general, and then you end up by more disease. And this has been stressed in the Australian group, again, after we published our, I think, lecture. By the end of, in November 2016, they have came with also nice publication showing how this cell is a risk factor for revision endoscopic sinus surgery if you miss it. Okay, I'm going to talk about the posterior ethmoids more when in a minute, but also I'm going to talk about the maxillary as a transition there. Now, you see this maxillary sinus? Let me ask you about this maxillary sinus. What do you think about this maxillary sinus is? I mean, why I'm presenting this is a lot of people, when I present this picture, they actually focus on the disease. So they mention the patient has left maxillary sinusitis, and you know, they forget about mentioning that the patient has actually a hypoplastic maxillary sinus. And the reason is you see the symmetry of the sinuses on both sides, so you tend to forget that this patient has a hypoplastic maxillary sinus, and you just focus on the disease on the maxillary. And how did I know that the patient has a hypoplastic maxillary sinus? Is by looking at the floor of the maxillary in all the cuts. So you see in all the cuts, the floor of the maxillary sinus never crosses below, this, you know, the line of the floor of the nose, this horizontal line. And then when you see this, see all the cuts, when you see this, you understand that this patient has a hypoplastic maxillary sinus, and then this example on both sides. Now, going to the sphenoid. I actually like to go to the sphenoid immediately after the posterior ethmoid, since we need to focus on the forgotten turbinate. And this forgotten turbinate, or the superior turbinate, is something that we need to actually search for during endoscopic sinus surgery, even in the middle of the polyps. Even in the middle of the revision surgery, try to find your superior turbinate. It's a great landmark for you to tell you, well, first you need to preserve it, right? You need to preserve the superior turbinate, upper 2/3 for sure, since you don't want to end with hyposmia for the patient, which is something that you cannot fix. So that's the first reason. The second is it's a great landmark for you while you enter the sphenoid sinus. Now, the class teaching is to have this parallelogram, or have this region lateral to the superior turbinate. Obviously, we are now looking at the left side, and then you say, okay, I'm going to have this line that divides this rectangle into inframedial area and supralateral area. And obviously, while entering the sphenoid sinus, you need to enter, if you are going transethmoidal, if you are entering the sphenoid sinus, then you need to go through the inframedial triangle, right? So this is going to be called the transethmoidal route. And then the other route for entering the sphenoid is going to be by entering through, well, you remember, I'm just going to actually, the other way is to go transnasal, medial to middle turbinate, right? But indeed, the most of the times, the way that we enter the sphenoid sinus is neither by the transethmoidal route nor by the transnasal route. What we actually do is we go and identify the superior turbinate, and then enter in the region between the posterior border of the middle turbinate, which is this, and see this region is very important. See, this region is pretty important. You have a window that lies, that I just showed in the first few images, a window that lies between the superior turbinate and the middle turbinate. But now I'm not looking at this window from the nasal view. I'm looking at it from the transethmoidal root, right? So now you need, I'm entering into this region, and then it's just as if I were entering transnasally to identify the opening of the sphenoid sinus just medial to the superior turbinate inferior third. So that's it. So I'm not going to be entering here. I'm not going to be entering here, obviously, through the superior turbinate upper half. I'm going to be entering through this region in most of the cases. Remember, again, concha plate should not be injured. Let me show you this, a live demonstration for this, or I would say the record demonstration, but a video demonstration. So you see, this is the posterior ethmoid region, and now I can enter through the posterior ethmoid right here in this inframedial triangle, but instead I'm gonna identify the superior turbinate and the region between, the window between it and the posterior border of the middle turbinate. In this example, since this is allergic fungal rhinosinusitis case, I actually am planning to remove the inferior third of the superior turbinate. So this is what I'm doing right now, anyway. And then just by doing, a little bit of trimming of this area, I entered into the sphenoid sinus opening. Remember, now I'm shaving, but I'm not shaving inside the sphenoid sinus. I'm just shaving at the opening. And while you are shaving at the opening, remember, you can actually endanger the septal branch of the sphenopalatine artery, but it's not a big deal. But you need to be prepared just in case you injure this. I actually prefer not to injure it at all by dissecting the mucosa a little bit, but just it came across in this case. So in this scenario, I'm just see, I'm now trimming this area as well, trimming this area, and now I'm removing the party wall between the posterior ethmoids and the sphenoid sinus. So I did not remove the superior turbinate upper half or upper 2/3. I just removed the very lower portion that does not have that much of olfactory fibers, and then the patient would not end by hyposmia. That's the postoperative view. You would see that's the middle turbinate in view, millimeter antrostomy for this extensive allergic fungal rhinosinusitis case, AFRS case, and you see the remaining part of the superior turbinate and the sphenoid sinus opening right there, posterior ethmoid roof. See, this is the sphenoid sinus, obviously. That's the ICA. This is the posterior ethmoid roof. That's the posterior ethmoid artery. You see as well all the way we are going to the frontal recess region, and that's the area of the maxillary sinus. Now, when you open the sphenoid very well, you might see the landmarks if the sphenoid is very well pneumatized. So that's, for example, in this case, this is the sella. You have the ICA bulge, the paracellular region, and the paraclinoid portion as well. And then you have the optic nerve right there. You have the OCR, or the optico-carotid recess, and that's obviously the area where the anterior wall of the sphenoid was. And this is the area of the bulge for, you know this? Okay, try to think, the cavernous sinus bulge, right here. And then that's a retromaxillary area of pneumatization in the posterior ethmoid cells. Sphenoid landmarks is something that we have, I think we have, like back in 2007, we have spent so much time in describing the sphenoid landmarks in different case scenarios and the variations that you would see with the internal carotid artery course in this region, the things that you would see in the cavernous sinus as well. That's beyond, of course, the endoscopic sinus surgery, but just came across this presentation, so I'm mentioning about all the details that you need to be aware of in the lateral wall of the sphenoid sinus. Looking into the sphenoid sinus landmarks, remember, you have certain foramina that are important. I'm going to show you one important, for example, variation that you can see in your cases. So obviously, this is the foramen rotundum, and you have, this is the really big Vidian canal, and you have the lateral sphenoid recess right here. Lateral sphenoid recess is even bigger and clearer on this side. I see the V2, the V2 canal, foramen rotundum anteriorly, and then the Vidian. See, it can, the over-pneumatization can put the nervous structures at risk. So you see this is dehiscent Vidian, can be dehiscent optic. You see the optic in the middle of the field. And then you see this pneumatization into the anterior clinoid process. I think maybe a couple of months back, we have demonstrated a case on my timeline showing a case with a really big pneumatization of the anterior clinoid process that held a lot of allergic fungal rhinosinusites, and the optic nerve was pretty much compressed, and the patient had, I think she had like hand movement, and you have to be very careful operating these cases, because you are going to be working around the optic nerve floating inside the AFRS or the polyps. And alhamdulillah, luckily, the patient went fine. Patient had regained her vision. Her father was just talking to me a couple of days back, since we are in the middle of the corona issue. So he's asking about the follow-up and so on. Sphenoid floor foramina can be, see, I'm going to show you this example. Oh, okay, so this video is actually not working. Okay, so anyway. Okay, yeah, so that's actually, oh yeah. So that's one of the cases that I was operating, and you see the Vidian canal was actually lying in a bony mesentery. You see this bony mesentery, and you see you have this Vidian canal, and you have also dehiscence on the V2 as well, just in the floor of the cavernous sinus. And you need to be very careful operating such a case, because what happens is, if you are widening the sphenoid sinus, taking down this bony mesentery, you actually will end by having injury for the Vidian canal, and then the patient will have a dry eye. And by the way, this was a revision case, was the 9th revision. Well, no, that was actually not the revision case. That was a different scenario. But I remember this case. So we have actually paid attention to this patient, where we identified the Vidian canal like in this bony mesentery, and then we saved the Vidian canal. But I remember another case, probably that was the case where the video was not working. Not sure if it's working. Okay, it's not working. So there was another case where we had a dehiscent Vidian, and in the middle of the field was her 9th revision, and then the patient ended with a dry eye for like 9 months since the Vidian was injured, and the patient luckily regained her teething. But it really was a stressful time for her and for me as well. But was her like 9th or 10th revision, and was extremely extremely distorted anatomy for this region. Now, for the sphenoid sinus anatomy as well, it's important to remember that you can have asymmetry in the sphenoid sinus. See this septum. So now literally, now what I'm going through right now is I'm entering through the left side of the nose. But when I enter into the sphenoid sinus through the left side of the nose, I'm actually entering into the right side sphenoid. And why is that? Because there is asymmetry of the sphenoid sinus septum. So you need to remember this. This happens a lot with our residents, so that they enter into the other side. And then if you just enter here and you think you are done, you are actually missing the true left sphenoid sinus on this side. And if you have disease in this case, obviously it doesn't have a disease, so it's not a big deal. But if you have disease in this case, then you can miss it. Sphenoid septations also attached to the landmarks, well-known fact. in this example, attach it to the internal carotid artery. It can be attached to the optic nerve. Also, the sphenoid septations can create for you some cells, whether they are cells over the clivus, by the way, or they are cells above the sphenoid, like the Onodi cell is important to recognize in order to clear them if they have disease. Again, dehiscent optic nerve inside the Onodi cell. As you enter anterior ethmoids, posterior ethmoids, sphenoid sinus, now you have a very much easier way to go from posterior to anterior along the skull base and clear this. Let me show you this. So that's now I entered the sphenoid sinus. Anterior ethmoids and posterior ethmoids are partially clear, not fully clear. So I'm now going to clear the cells on the skull base, starting from the sphenoid sinus posteriorly and going anteriorly over the posterior ethmoids and then the anterior ethmoid. Right here, I'm taking it down cell by cell over the skull base, the skull base of the posterior ethmoid, skull base, and then the skull base on the anterior ethmoid, and the cells on the lamina propria as well. So taking them carefully from posterior to anterior in order to clear all the disease of the patient. As you see, I'm telling from the sphenoid, posterior ethmoid, going. As you see, the navigation is showing you where exactly you are going, all the way to the frontal recess region. And as you see postoperatively, you see the remaining part of the superior tablet. All the cells over the skull base are clear. Well, the sphenoid, as we just described, has important landmarks to the optic and to the ICA. This is an example of a patient that had not just optic compression with she was having optic atrophy, optic compression, and she was having pretty much hand movement, or even there was just perception of light on the left side, and also compression on the internal carotid artery as well. And you need to be very careful again, looking into these patients and operating them. In this example, I'm using the navigation as well, intraoperative navigation. MRI was done as well for the patient in order. Let me show you the MRI. So you see the MRI, the internal carotid artery. So you see, okay. So as you see, the MRI is also showing the internal carotid artery pretty much not in the middle of the field, but in your margin, like you will touch the internal carotid artery. I'm going to show you the intraoperative scenario right now. So you see the internal carotid artery right here, and obviously all the investigations has been done for the patient, whether it's ophthalmology, MRI, full assessment, in order to see this is. So that's the area where you see allergic mucin, and then you see the internal carotid artery turn, the C turn over here. See, this is the allergic mucin, and I'm going to show you also the ICA right there. So the ICA is going. So that is the ICA on the other one side, and this is the ICA. And remember, why I'm showing you this, because this patient has perception of light, or probably hand movement, and the patient needs a full clearance of her allergic mucin in this region. You can't just go there and leave this behind, because this is the target. This is the aim of the operation, is to clear all this allergic mucin from this region for the patient to have hope of regaining her vision. What I've done is extended sphenoidotomy, posterior septectomy, doing pretty much what you do for a pituitary surgery, and then clearing all the cells inside the sphenoid sinus. And I'm going to show you this region. So you see, I'm now working at the very narrow area that I showed you in the CT and the MRI scan on the left side. And I'm taking down this region. While I'm taking down, I think I'm going to have injury again of some, like you see, let me show you. So while taking the septum down, I think I'm going to also again injuring one of branches, probably of the septal branch of the sphenoid artery. Again, getting in this example, the bovi or the suction diaphragm, very carefully. You see, the IC is just back there, right? So you need to be very careful. and then, okay, let me just, okay, clearing this region. And again, see, now I'm showing you. See, can you see this band? Probably some of you now will start. Can you imagine just you are inside the surgery and you know this patient has a perception of light. She has severe deterioration of her vision. What exactly is this band in the middle of the field? But you need to be very careful working around your landmarks, just brainstorming what exactly this band is going to be. Well, I put all the scenarios, what this can be. But you see this mucosa right here. But you know the anatomy from your CT and MRI. You have also the navigation there. But you see that this seems like a mucosal band. The mucosa on the left side of the septum that has, as you remember, we have a very narrow left side on the sphenoid sinus, and we have this mucosal band on the left side of the septum. So I'm now clearing. See, but by the way, once this was cut, I was like, oh, it looks scary, since it's very tough band out of the chronicity of the disease that the patient has had. And now I'm clearing, taking down the septum again, and I know I'm pretty close to the dehiscent optic and the dehiscent carotid artery, and you see this allergic mucin that's pressing on the optic nerve up there, and this has just so much pressure with so much disease that the patient had pressing on the optic nerve right there, and then this all was cleared out. And I'm going to show you the postoperative picture for the patient. See that? Can you see the pulsations of the dura right here, of the cella, pulsations of the ICA and the optic nerve? I'm going to show you the postoperative result, which shows you clearly what exactly you have had. By the way, this is a partial middle turbinectomy, a partial one to allow the postoperative irrigations to reach this region very well. And see, this is the extended sphenoidotomy right there. And you see that's the dehiscent ICA pulsating, and you see the cella, you see the optic nerve right there, the OCR, this region is pretty much clear. And by the way, the patient has regained almost full her, most of her vision. She had still remaining a little bit of blind spots in the field, like in the visual field, but the patient was extremely happy, almost sees like normal, and was really exciting case. That's one of the quiz that we do while doing the dissection. So I'm pretty sure now you can spot this is the cella, that's the ICA, optic nerve, OCR is going to be here. You have a septum on this side, on the right side, that does not make the paracellular ICA pretty clear. But this is the clivus, this is the paraclival ICA on this side, paraclival ICA on the other side. Again, okay. Now we go to the frontal. Well, going to the frontal, I'm going to ask you a question, and hopefully I'm going to see your answer. I'm going to give you 1 minute to answer this question before I give the answer. So the frontal, can you summarize the frontal in 2 words? And I'm going to look at the comments later during my review of the lecture later, but just try to summarize the frontal in 2 words. If you can, put some like comment on the video, 2 words to summarize the frontal. And I have it summarized in 2 words, and then we're going to move forward. So hopefully by now, I'm not sure how much lag do I have, and how much time did you have to like, I'm not sure how the lag is going to work with you guys, but now let's see. So the 2 words summarizing the frontal is it's a separate lecture. I simply cannot, summarize the frontal in 2 words, and I simply cannot mention the frontal among all these details that we are discussing in, the landmarks lecture. So it's basically a separate lecture. So much detail in there, so much landmarks in the about the frontal, and so much demonstrations that we need to go through in the frontal that deserves to be a separate lecture. That hopefully when we see some of you in our courses, or maybe in one of the meetings, we can go through the frontal in more detail. Now, for the ethmoid arteries. For the ethmoid arteries, the anterior ethmoid artery lies in a bony mesentery in 1/3 of cases. So, which means in 2/3 of cases, it's going to be lying in the skull base, right? But in 1/3 of cases, it's going to be below the skull base, in 1 to 8 millimeter below the skull base. And that's an example where you have anterior ethmoid artery lying below the skull base. Let me show you this. What is the anatomical variation that's going to actually make you predict that the anterior ethmoid artery is lying below the skull base in when you have a supraorbital pneumatization? So a supraorbital pneumatization, pretty much in most of these cases, you will have the anterior ethmoid artery lying below the skull base. Again, in this example I'm showing you is a supraorbital pneumatization right here. And the anterior ethmoid artery is lying below the skull base. And let me show you this example. Now, I'm going to show you this example because this is the scenario that I actually find most dangerous. So, most of our residents know that the anterior ethmoid artery can be lying below the skull base in 1/3 of cases. So they review the anterior ethmoid artery before they go to the operation, and they see the nipple sign. The nipple sign. See, I'm pretty sure you see the nipple sign right here. This nipple that lies between the superior oblique muscle and the medial rectus muscle. So they search for this. But what you guys don't search for at times is a dehiscent anterior ethmoid artery, which can be lying at the skull base. And this is in my opinion, the most dangerous scenario because you are not prepared. And I'm not just my opinion. I have seen in my career 2 cases of anterior ethmoid artery injury. Fortunately, not done by me, but they are actually referred to our institution where they had previous history of anterior ethmoid artery injury intraoperatively, and then they are coming to our institution to have the revision scopic sinus surgery done, since it was not completed in the first surgery. Obviously, in the middle of the anterior ethmoid artery injury, the first surgeon just stopped. And I have reviewed both cases, and you would see I have reviewed actually the preoperative CT images for both patients and find them pretty much looking in the same way that I'm going to show you right now, looking something like this. And what is that? Is that's an anterior ethmoid artery lying in the skull base, but with eroded bone. Like you don't see bone below the anterior ethmoid artery in the skull base. And that's in my opinion, the most dangerous scenario. See, it's a little. You don't have anterior ethmoid and supraorbital pneumatization. You have an anterior ethmoid artery region that's pretty much having no bone here, right here, and then the patient can very easily have injury of the anterior ethmoid artery during surgery. So we have. This is the patient that was a fresh patient. That was not a revision case. So I'm just showing you how the field is going to appear intraoperatively. So this is the same patient. A same patient, I'm going to be showing you. So again, this is not a revision surgery. This is a fresh case. Patient did not have anterior ethmoid artery injury. I'm going to show you how the field looks like intraoperatively and how it's very likely, or very risky while you are operating such a case. So that's the left side. That's the posterior ethmoid artery, also dehiscent, very clearly appearing in the field. And then you have the skull base between the anterior and the posterior and the anterior ethmoid artery. And then you have the anterior ethmoid artery right there, just in the field. It's just in the field. You remove the polyps, it's in the middle of everything. And then you have the first fovea, the space between the anterior ethmoid artery right there and the posterior table of the frontal. And again, I'm just showing this region. See, I'm just putting the suction around, but the key is identifying the anterior ethmoid artery when it's dehiscent in the middle of disease. So that's it. That's the anterior ethmoid artery. See, that's in the patient. That's the anterior ethmoid artery region. And you see this is the first fovea, the space between, or the roof of the suprabulbar cell, right? So it's the roof of the suprabulbar cell, and then you have the posterior table of the frontal right there. The posterior ethmoid artery is pretty much most of the cases in the skull base, 98%, but then in 2% of the cases, you might find it below the skull base. Again, that's when you have posterior ethmoid supraorbital pneumatization, like in this example. Pretty uncommon, but you have to pay attention to as well in your cases. That's a demonstration of a postoperative case showing you everything opened up and what you need to have in your polyp cases, AFR cases, revision cases, pretty much clearing everything and opening things up wide. Let me show you. So that's the left side. That's the middle turbinate trimmed in order to be nice looking, not obstructing the airway. That's the superior turbinate. The inferior third was removed. So, and this is the sphenoid sinus opening. That's the roof of the posterior ethmoids right here. This is the posterior ethmoid artery, again appearing in this case anterior ethmoid artery, and the space in between them. This is again the first fovea, and then you have the posterior table of the frontal recess. That's the lamina papyracea. And let me show you on this side. I see this region. So this is our cell, right? So this is our cell that we described. I like to focus on this because remember, again, I'm showing you this retromaxillary cell, and this is the lamina papyracea right here. Remember, if I would have missed this cell, now let me show you what's going to happen. If I would have missed this cell, I would have a cell right here, which means I'm going to be having a cell right here over the lamina, and then which means that this area of the posterior ethmoid wouldn't be clear, and then you would have this area harboring disease that's going to form polyps, and the polyps is going to come over the frontal sinus ostium, sorry, the sphenoid sinus ostium, and then you end up with, obstructing the posterior ethmoid, the sphenoid, the posterior sinus group with a disease, and then the patient ends up with recurrent disease. So again, the cell and showing you this again. By the way, I have a separate lecture describing the posterior ethmoids, how to work on this region and the relationship between the posterior ethmoids and the maxillary sinus in what we call the ethmomaxillary crest, and how is that important in clearing the cell of the. But that's a long story in a separate lecture. Again, on the other side now we have the sphenoid sinus, the superior turbinate upper 2/3. You have the skull base, a band here. See, this is the anterior ethmoid artery, a band in front of the anterior ethmoid artery that I have missed. But unfortunately, you don't have any complete partition that's going to harbor disease. Again, the retromaxillary cell, you can call it Herzella cell. I like that name, of course. And again, that's the cell. And then the middle meatal antrostome. Lastly, before you go for surgery and before you finish your surgery as well, you need to review the septum, the turbinate, and the nasopharynx. Septum, since you might end up, doing all the surgery, right? You clear everything, you clear the frontal, you do everything, but then you miss a septal deviation in the middle of the disease, or you get tired or something and you don't work on this appropriately. So it's going to end up by recurrent nasal obstruction, and then you would need to operate the patient again, which is something you don't want to go through. So you need to review the septum, and obviously the septum itself, if you do the septoplasty, is also going to help you work on the sinuses, especially if it's obstructing the sinuses enough to prevent you from working on the sinuses in the proper way. So the septum. The turbinate. Again, I was in Rhino, Egypt this last March, and we have a separate lecture on the middle turbinate, right? We had a separate lecture on how to deal with the middle turbinate in endoscopic sinus surgery. Again, there are so many examples on what to do with every scenario, but just one example is the concave allosa. Why I'm mentioning this, because it's pretty common to have remember, concave allosa is pretty much like 20% of cases, of normal cases, right? So you should expect to have a concave allosa in the middle of the diseased cases as well. And the patient is not coming for concave allosa, the patient is coming for the polyps. So surgeons tend to miss the concave allosa in the middle. I'm not talking out of like just cases that we see, out of even publications showing the percentage of concave allosa in revision cases where the surgeon have missed, where the surgeon has had missed the concave allosa in the first surgery. And by the way, this is an example where I'm asking my resident to work on the case, and he was like, okay, he's trying to get into the middle meatus, identify the answering process, and start removing the polyps, doing the middle metal-anthrostomy, and he's like stuck, trying to medialize the middle turbinate to get into the space, but he can't do it. It's kept like for 5 to 10 minutes trying to do it appropriately, and I'm like, listen, if you don't review the CT scan and you see that there is a concave allosa in the middle of the polyps, you need to see it very, it's sometimes hard to identify it, but you need to go through all the cuts to see it. Unless you do this, you wouldn't understand that this is not just a polyp, it's a concave allosa that you need to work on. And once you open the concave allosa, do it very well. You see a nice wide middle meatus right now, and then you can do the maxillary anthrostomy, identify the answering process right there, and do the maxillary anthrostomy very easily now. Even another example for working with the middle turbinate, again, I'm telling you there are so many different scenarios that it's a separate lecture, but middle turbinate partial resection is another option, and middle turbinate partial resection is helpful in certain cases. It actually can help olfaction because it prevents all the disease reforming polyps from obstructing the olfactory cleft, but it has to be done very in a good fashion. You don't need to be aggressive. It has to be done for selected cases, and the middle turbinate partial resection is helpful in such cases, in such extensive cases. The last thing is to review the nasopharynx, since the nasopharynx can have adenoids, right? The patient can have adenoids, and you do all the work nicely, the septum, the polyps, the disease, and then you miss adenoids in the nasopharynx, and then the patient comes with recurrent nasal obstruction again. So just to review, take-home messages. The claviform plate is not just the keros. Remember the medial orbital floor where you have different variations. Remember the number 14 millimeter plus minus 3 standard deviation. The lamina pepacium, or just the head sense. Remember the types that we described back 5 years ago. The types type 1, type 2, type 3, and the implication of each type on your case. Remember the cells in the ostomator complex, the Onodi cell, and also our cell or the retromaxillary cell, where you can have disease and needs to be taken care of. The sinuses, remember the forgotten details that we mentioned in the sphenoid sinus, in the maxillary hypoplasia. Sorry about the frontal. The frontal has to be a separate one. It's 1 hour separate. Remember the ethmoid arteries, where you have not just the lying down ethmoid artery, but also the dehiscent anterior ethmoid artery. And remember to review the septum, the turbinates, and the nasopharynx. Use the closer in your patients. Teach it to your staff, teach it to your residents. It's something that if you use every single one of these letters and go through all the details that the letters tells you, it's going to help you review the CT scan very well, and you will have a map in your mind in order to get into the surgery, knowing exactly what you are working on. People tend to see the disease only, like tend to see, okay, the patient has posterior ethmoid disease, anterior ethmoid disease, frontal disease, tend to see certain details in the CT about, like, anterior ethmoid artery, tend to see whether there's dehiscence in the skull base or the dehiscence in the lamina, and they tend to forget all the other details if they are not reviewing it in a systematic way. And I like the acronym CLOSER for this. So look closer. Hopefully you will stay safe and effective. I'm missing my colleagues in Zagazig, of course. By the way, I'm now in King Abdullah Medical City for the last 6 years. King Abdullah Medical City, by the way, King Abdullah, sorry. Okay, so King Abdullah Medical City, oops, I have to, okay, so I've been working in King Abdullah Medical City in Mecca for the past 6 years. We have a set of subspecialties: rhinology, head and neck, facial, plastic, and otology, lateral skull base as well. And this subspecialty-based career or subspecialty-based practice is actually one of the things that's going to help you develop a lot of skills and a lot of details in your career. But I'm missing my colleagues and my friends, my brothers in Zagazig University, and all my colleagues in Egypt, of course. And I'm very happy to have this lecture today for all of you guys. I hope everything went fine. The streaming was clear. Hopefully things, from the technical point of view, was fine. Hopefully the presentation itself was, helpful for you guys in your practice in the future, inshallah. It was, very nice, talking together. Well, actually, there is no interaction, but I'm going to have a look at your comments in the section, inshallah, and see how much it, matched your expectations and what exactly you need in the future, inshallah. This is the holy city of Mecca. It's very like heart-touching not to have access right now to all the holy area of the holy mosque. But inshallah, things will settle down soon. And inshallah, you will come for Umrah as well. Everything, inshallah, is going to be fine in the near future. Right now, everybody, I'm pretty sure everyone is having difficult time with this COVID-19 thing. And inshallah, things will get better soon. And we will go back to our normal lectures where we have not just the lecture broadcasting, but we have much better face-to-face communication, interaction, social, interaction is I think, apart from the scientific point of view or the scientific thing, the social things that we have in the meetings is a lot more exciting than just a broadcasting. So inshallah, we will catch up together soon. And again, reminding you that, sorry, I didn't put a slide for this in my presentation, but let me tell you something. Middle East Academy of Otolaryngology meeting that I have the honor to be handling, to be taking care of for the last 4 years in Dubai. The Middle East Academy, I'm taking care of just the rhinology portion. So the rhinology portion or the rhinology section or the rhinology track in the Middle East Academy is something that we have been keen to be a major part in the meeting and to be distinguished. Last year we had 35 speakers. All of them had outstanding input in the meeting. They were from 15 different countries. And this year, inshallah, is going to be in October 5 to 7. Sorry, I did not put a slide. I should have done that. Let me check. Maybe I missed the slide. But it's not there. But it's going to be 5 to 7 October 2020. 5 to 7 October 2020. That's going to be the Middle East Academy of Otolaryngology in Dubai. Again, the rhinology section is going to have 35 speakers, again from almost 14 countries this year. You know, you will see a very rich program with unedited recordings for you know, surgical, not just dissections. Some are dissections, but also unedited surgical or minimally edited surgical videos. You know, sessions like 30 to 45 minutes, where you have our distinguished speakers talking about you know, some skull-based cases or some extended sinus surgery cases, showing you unedited videos in these sections and describing what they need to describe on these videos. In addition to the instruction courses that we will see you there, and you know, I'm pretty sure you should have all the eager to go out of your homes after this Corona COVID-19 thing, and then hopefully the first thing you are going to think about is coming to Dubai for this meeting. Thank you, and now I'm looking forward to see the whole thing on the group. Thank you very much, and see all of you inshallah soon. Thank you.